Good morning, Tracey.
Kia ora.
We allocate 10 minutes for you.
Kia ora. Tēnā koutou, tēnā tātou katoa, ko Martin te whānau, ko Mohi te whānau whāngai, ko Ngāti Kahungunu ki here tonga te iwi, ko Tracey taku ingoa. My name is Tracey Martin. I'm the Chief Executive of the Aged Care Association. I just want to be really clear, I do not represent retirement villages. I represent 90% of those who provide aged residential care. 66% of those are not-for-profits, charities, community trusts, and small owner-operators. I am taking our submission as read. Our association fully supports the goal of ageing in place, but not if that definition is ageing at home at all costs. Our association supports the goal of ageing in place when that place is community of the elder. Our members, residential care providers, are members of those communities too. They are a vital part of the continuum of care. Mr. Chair, statistically, only 28% of over 85-year-olds will require residential care. A lower percentage will require secure dementia or psychogeriatric care, but there will always be a percentage of our elders who need one, if not more, of this care provision. Too often, we are hearing the word burden when referring to our current generation of elders. They are not a burden, they are us. Everyone over the age of 30 and above will be part of this wave of elders that does not peak until 2078. One of the current trends, 1 in 4 of us will develop dementia. This is about them and this is about us. The question this inquiry is seeking to answer is if the aged care sector has the current and future capacity to support services for people experiencing neurological cognitive disorders. The short answer is, under the current funding and delivery model, no. The long answer has been reiterated time and time again inside a number of very expensive reports commissioned by government and government agencies. The most recent of these is the Sapir report from earlier this year. Over that time, the aged care sector has become less and less sustainable. The level of loss being absorbed by our members has increased to the point where almost all providers are having to charge accommodation premiums on top of the 24-hour care rate to be able to stay afloat. How did we get here? Much of what we're dealing today is a hangover from the sector restructuring of the 1980s and the 1990s. This was when government decided to get out of the business of residential care. This is when government asked and incentivized private providers to step in. Commentators at the time said, and I quote, patients, families of patients and carers were caught in the cracks, and there were harrowing and occasionally tragic tales of poor communication, missed opportunities, poor support, lack of continuity of care, and unsuitable placements. You will be hearing similar statements again and again and again through the submissions to this inquiry. However, right now, aged care is being redesigned behind closed doors. We and our colleagues, home and community, palliative care, peak bodies representing dementia, Alzheimer's and gerontologists have been excluded. Designing a new delivery and funding system without on-the-ground experts will result in a short-sighted and short-term fix instead of the affordable and sustainable system change we need. Once again, government appears to believe it can save itself money while passing on the risk and cost to New Zealanders in need, their families and the providers. We should not forget that those New Zealanders in need whose assets and income fall below the current thresholds already pay all of their income and have to sell down their assets before government providers will top up anything for their care. The snippets we have collected from this whiteboard session and that slide presentation indicate to us that Te Whatu Ora is creating a model that is being driven from a completely financial perspective. They have been instructed to find a way to release 200,000 hospital bed nights to ensure that less New Zealanders can access residential care, and that much of the work they are doing is based on several questionable assumptions. Of direct concern for this committee should be Te Whatu Ora's articulated belief that dementia needs will increase only mildly, and that psychogeriatric need will remain flatline for the next 15 years. We do not know what evidence they have to support this assertion, but the very real consequence of this belief is that no thought will be given to in the redesign to the reality that no more psychogeriatric beds are being built, and that the current stock is heading towards 50 years old. Nor will any effort be placed into dementia care provision, both in community and residential care. Te Whatu Ora themselves cannot find current placement for New Zealanders who need this level of care. Individuals are being inappropriately placed by Te Whatu Ora with our members due to the lack of appropriate places, putting at risk other residents and staff. But Te Whatu Ora then ensures it's very difficult to have the individual reassessed. Our members are beginning to feel like they are at the bottom of this particular health ladder. We have population growth, we have an ageing population. Our members are seeing greater incidence of alcohol and drug-induced dementia that is tending towards more violent and unpredictable behaviour. Currently, around 89% of all of those in residential care have some level of cognitive decline. This is underreported. Many are not at the stage where they need to be in a secure facility, and they may never get there. They are managed inside residences, but the number of those that do need secure support will rise. Without a funding model or contract incentive that supports renovation of existing facilities and provides the capacity to take the risk to build new facilities, then current places are very likely to be closed or at least retracted due to age. As the committee is also considering the appropriate thresholds for care provision, we draw their attention that as part of the redesign, Te Whatu Ora has articulated lowering of the asset and income thresholds to access residential care so that elder New Zealanders will pay more and have less, and raising the level of frailty to be able to enter residential care, leading to the possible removal of rest home level care completely. I have visited a lot of residential care facilities over the last 5 months, and I can tell you I've not met a single person who could have been living at home. Now, nor will this mean that the people assessed as needing the support of rest home level care will magically be less frail. They just will be frail at home. At the same time, consideration is being given to removing the lower levels of home and community support, levels 1A and 2B. I haven't pulled these things out of the air. I can provide the select committee with the slides, with the evidence upon which we have based these statements. We have been told by Te Whatu Ora officials that they have a working assumption that predominantly or approximately 20% of the current residential care population could be cared for at home. To do this, they have calculated that the home and community sector will need another 8,000 FTE annually. We do not know where this workforce is coming from. We suggest that the committee look at the example of Wairoa to see what is a possible future for our elders and their whānau and families if this redesign is done badly or is indeed ignored. Mr. Chair, in 2012, the Education Science Select Committee initiated an inquiry into 21st century learning environments and digital literacy. Once it became obvious to the committee that a government agency was in the process of designing a digital transformation from the wrong perspective, the committee chair, representing the committee, suggested the minister responsible pause that work until the committee had finished its inquiry. I tell you this because I want you as a committee to know what you have the ability to do. We believe New Zealand can create an affordable, community-based, sustainable solution to the obvious and agreed need that we face over the next 50 years. But we do not have confidence that a government or its agent can design this practical, safe and sustainable model without us, all of us. The peak bodies that deliver for real people with real lives through the expertise of our members. In our written submission, we outlined a number of overarching key settings that we believe will help improve the system, but our suggestions need to be joined with those of the home and community care sector, the palliative care sector, Alzheimer's Dementia New Zealand, and best practice and research from the Gerontologists Association. We ask the committee to consider requesting the Minister of Health place a pause on the aged care sector redesign. We ask the committee to recommend with some force a ministerial task force or multi-ministerial forum that includes representatives of the peak bodies and other key stakeholders such as Alzheimer's New Zealand and Dementia New Zealand be created with urgency to provide full sector involvement in the redesign. We want to work with government. We want to get this right, and we want it to be sustainable. We want to ensure that as a nation, we can hold our head high, because every New Zealand elder has what they need to live and die with dignity. Kia ora, Mr. Chair.
Thank you. I know that members got questions, but we actually run out of time, so unfortunately we can't ask anything. But feel free to stay behind.
Point of order, Mr. Chair.
Yes.
This is a really important submission. I think members of the opposition would really welcome an extra 5 minutes so that we can ask some questions.
What do you guys think? All right,
I'm happy for that.
Thank you.
Yeah.
if I agree. Yes, so we got 3 questions.
Well,
We
we're going
got-
to ask our submitter if that's
That's fine.
fine.
I'm
All
happy
right,
to
are you fine for? All right, so we got 3 questions. So I will go with Imran first, and then Vanessa and Jenny last.
Thank you very much. I can hear the frustration in your submission. We've heard about the 200,000 bed nights. Can you please clarify, is that across Te Whatu Ora or specifically for seniors?
Specifically hospital beds. So
Right.
it's about releasing hospital beds.
The rural sector, you are on record as saying you have the most concern about.
Yes.
Can you please describe what the impacts will be on people living in the rural sector if we don't get this right? And thirdly, Waikaha has a freeze. We have disabled seniors living in the rural sector. How concerned are you for that community?
So to the first part and then the second part. So with the first part, we have around about 205 of our members are classified by Te Whatu Ora as being rural providers. Around about 111 of them would be most likely to close their businesses if rest home level care was removed completely. We would have to work with those businesses to try and pivot to respite care, day care, and some of the other things that they provide, but we are very concerned that around about 111. I can provide the committee with a breakdown with a colour-coded level of risk of those.
Just to clarify, though, I was thinking about the people who use those services. What's going to happen to them?
There will be no services there. Home and community, if they are well supported for a period of time, may be able to step in, certainly. But for that 28% of over 85-year-olds that we are seeing consistently require in residential care, if Wairau is an example of the levels of stress and difficulty that families experience when there is no respite provision, that is what is the future for our rural communities.
All right, thank you. I'll just move to the next question to Vanessa.
Thank you, Tracey. Acknowledging the, I share your concerns about Te Whatu Ora's capacities, frankly, and to be able to redesign the system. In this, you mentioned a request for a ministerial task force. Do you think that the Ministry of Health has got the capacity to do that as well?
If we had I think really what we need is a multi-ministerial task force based on probably what was the future of work model that was under the 2017 to 2020 government had in place. Because this is part of this is actually incentivising new builds. So we need infrastructure in there. We need the Ministry of Health in there. We need MSD in there. MSD is nowhere in these conversations. So without, I don't want to take away from the Ministry of Health, they're all under pressure, but we have the solutions. We would like to be part of working it through with them. Then we'd own part of the solution too. Can only be good for them.
Yeah.
Thank you. Jenny?
I was going to ask about that, but I'll ask my second question then. One of the things that you recommend, thank you for great submission, such great detail, really helpful. You talk about the funding equation and breaking it down into 3 parts. Can you extrapolate that on for us and
Certainly.
give us a bit more of your thinking on it?
Certainly. So every New Zealander has the right to believe that they will receive the level of care that they need from their government for the period of their lifetime. And so regardless of whether you are in a high-end aura-based care suite inside a big 6 facility, or whether you are in a small facility in Gore, the level of care is the same. It is audited, it is constantly monitored, the level of care is the same. What is different is the accommodation, and what is different is the living expenses, and so the food, the this, that, and the other that is provided. We believe by separating up to give greater transparency to what is the cost of actual care, the cost of accommodation, and the cost of living expenses, that one, Te Whatu Ora would be responsible just for the bit that Health New Zealand should be responsible for, which is care. Then there needs to be a conversation. New Zealanders understand that if they weren't in a residential care facility, if they were at home, they would have to pay rates, they would have to be paying their power bill. We can give them transparency of that so they can see where their superannuation is going to pay for those things. And then MSD should be part of the conversation, because if that senior was at home and unable to pay there, they would be putting in an accommodation supplement. So we think by splitting it up, we've got greater transparency. We can have a good look at where the actual health costs are, where the other costs are, and we can manage that across the sector.
All right, thank you so much for your submission.